Hi, my name is Nancy Albert. I'm a nurse scientist and clinical nurse specialist in heart failure from Cleveland Clinic in Cleveland, Ohio. We're here to welcome you to the late-breaking clinical trials discussion. The clinical trials were released today on prevention and lifestyle.
And I'm Mikhail Kosiborod. I'm a cardiologist at St. Luke's Medical Heart Institute.
My name is Appel. I'm a professor of medicine at Johns Hopkins, and I'm a clinical researcher that focuses on prevention of cardiovascular disease.
And Nancy, this morning's session was really addressing the 2020 goals very nicely, because I guess the two major themes were the prevention and medication adherence. And the medication adherence in particular has been very, very difficult issue. These trials are very difficult to do, and one of the trials was presented this morning. What do you think of it?
Well, the medication adherence trial was unique because it included pharmacists and it included a bundled intervention. And we do know that most interventions that are single interventions do not really work as well. So we had a great bundled intervention, and we were able to show an improvement in usage of the right drugs. But unfortunately, we weren't able to see outcomes that were important and meaningful, like mortality and rehospitalization. So obviously, we were able to get a small effect, but not big enough effect to really make a difference. The one interesting part of that study was that they used a voice messaging system to get the intervention across to patients. And it may have been that because it was a voice messaging system, for the majority of it, there was some in-person education as well. But the voice messaging system may have been thought of as a little bit distant to a patient. Maybe the patient didn't think they were getting as much attention as they would get if they had a clinical provider there all the time, and that could have made a difference. It may be that if they tweak the intervention a little bit and try something different, a different combination, they would get better outcomes.
It's also one of the, there's also a problem in the sense that they recruited just everybody as opposed to those who have problems with compliance. So at baseline, their compliance was extraordinarily good,
yes.
You know, and so there was almost like a ceiling effect. And also, it's relatively small in scope. I mean, small in size, only a few hundred. So it would be tough to see mortality, but they didn't see much beyond improved compliance with pills, and there were no effects on blood pressure and some of the other variables we're interested in.
The other thing of interest is that they used 80% as the cutoff for adherence, and there is not any literature out there in the acute coronary syndrome patient population, but in heart failure, the cut point to see a difference in outcomes is a little bit higher. So if they reanalyzed the data and looked at different cut points, they may actually get different outcomes. It would be a very interesting phenomena if they were willing to do that.
Yeah, and also perform the subgroup analysis on people who were less compliant at baseline.
That's right, very good.
Yeah, it was very interesting actually. One of the findings I felt on the slides that was quite interesting was that the patients that were randomized to intervention who were not adherent, they seem to actually be almost like violently non-adherent. I mean, the LDL levels were like 25 points higher than the non-adherent patient in the control arm. So it seemed like those are the patients that are truly not adherent because they're not adherent even under the intervention.
Nothing's going to make a difference, yeah.
Right, and that may be the group that probably will be very difficult to intervene on regardless of what you do. But those patients that, Larry, you said, that are maybe not adherent but are amenable at least to improve adherence would probably be the population you want to focus on, right?
Sure.
So what about in your study? So you had Chinese patients and they were receiving sodium substitutes.
Right.
Tell us a little bit about that.
Yeah, so that was actually a study that, ideally probably had the biggest potential for global impact in terms of both prevention and health policy. And so that was the Rural China Health Initiative, SALT reduction study. And what they did essentially was a cluster randomized trial, cluster randomizing villages in rural China to either kind of no intervention or usual care, so to speak, versus a two-phased intervention. One was just educating the villagers on dangers of salt intake, and then there was an extra intervention in half of the villages that were randomized to intervention to actually get a price subsidy for salt substitute. And then the salt substitute was distributed to villages, all the villages that were randomized to intervention. And the primary outcome, interestingly enough, of the study was reduction in a sodium intake that was measured by urinary sodium excretion. And what they found was that there was very kind of clinically modest but statistically significant reduction in urinary sodium excretion, essentially meaning that there was a very modest but statistically significant reduction in sodium intake, and that did not translate in a significant blood pressure reduction, probably because how modest the effect was on sodium intake. And the big question here is, would an intervention like this truly have an impact on a global scale when the effect on blood pressure is essentially not there, and the effect on sodium intake is so modest? And Larry and I spent a lot of time talking about, actually, as far as the sources of sodium. What do you think? I mean, I know there are some data in the West about where the sodium comes from in the diet, and we've talked a lot about what that could have impacted the study.
So in China, particularly rural China, the sources of sodium are actually sodium added to foods. Right at the dinner table. So probably, I would say probably over 50% comes from using the shaker, whereas in the United States, it's only about 10%, and most of the sodium comes from processed foods. Actually, one of the more interesting comments I think that is relevant to the study came from the audience when one of the I think he was an investigator in the study, asked to comment about the replacement. So these people had to buy, the salt replacement.
And it was expensive.
And it was more expensive.
And it was a distribution issue.
And it was a distribution issue. And so they basically had to run through their own salt, the salt that was there at home, before they would start using a new. And so I was thinking, well, if you really want to test the hypothesis that, the salt substitute actually can do something, you give it to them, you know, and then you say.
And you take away the
You take away the old stuff, you give them the new stuff, and then you can test for, well, what would happen if this were the sodium substitute that everybody used? Because I think it became a bit of a mixed research question, both compliance and efficacy in the same study, and those are a bit complex to interpret.
And then the other issue, which I don't know how common, you may have some more insights on that, Larry. The salt substitute that they used actually was between 60 and 75% sodium. So, I mean, if you look at it, I mean, there is a stepwise regression, where what you use is majority sodium anyway, even though it's a substitute. Then there is a distribution issue, and the fact that they have to pay more for it. And then they actually weren't told that they can only use salt substitutes. They could use table salt and salt substitutes, so there is a diffusion there. Mm-hmm. And so when you look at all these kind of attrition factors at the end, it's not too surprising that the effect was relatively modest.
Yeah, it's interesting. I'm not an expert on salt substitutes, but basically 65% of the salt substitute was still sodium.
Right.
The issue is that potassium in SI salt can have a bitter taste, and so they really do have to titrate that to an acceptable product that it can be used in place of sodium. Interesting, in the United States and other, actually I don't know the product name, but they figured out ways where you can maintain the salt preference, and they actually changed this crystalline structure of the salt, so
maintains the taste.
It maintains it, but instead of like a solid crystal, just the outer part of it is sodium, and that's sort of like hollow on the inside. So it's sort of an intriguing way where people still maintain their preference and liking, but it's reduced. To me, not the optimal approach, but obviously this is a technology that might become available.
Right.
So maybe if they switch their intervention and make it a little bit different, they would have better outcomes.
Potentially, yeah.
Yeah, but we were just talking about this before this. We started this conversation with Nancy about how impressive those graphs look when you look at the total number of patients with hypertension in China. I mean, the numbers are really staggering.
And China is obviously a place where stroke is a huge issue, and stroke is clearly a blood pressure dependent phenomena, with estimated well over half of strokes related to elevated blood pressure.
And they're still a young country, so as people start getting older, it's really going to elevate something they really need to take into consideration.
It is a huge tsunami that they're going to be dealing with, and when people get strokes, the debilitation is obviously a major concern and a major stressor on society and resources.
So I guess the bottom line is that these types of studies are clearly necessary. There is a huge need from a public health standpoint everywhere in the world, but particularly in China, to address it, and it hopefully will be the first step to try to figure out how to fine-tune the intervention to make it better.
Right.
Sure.
So tell us a little bit about your study and what the results were and what the implications are.
Okay, so the study that I was asked to comment on was a study that tested intervention with social networks, and it was very interesting. It was done with the support of a nonprofit company called MicroClinic, which actually is interested in social network type interventions. And the investigators from Harvard identified a community in rural Kentucky where obesity prevalence was high and where it was basically an impoverished community. And they did similar to the previous study, a cluster randomized trial where certain groups got assigned to a control group and another group got assigned to a behavioral intervention that recruited clusters based around an individual, and the cluster was then given an intervention that included information, but they were also taking advantage of the existing social networks, hoping that that skills and attitudes would diffuse through the group. Basically a test of some of the social network theories that are documented, that obesity and smoking and alcohol, actually appear to be correlated with social networks. So in the end, after about 10 months of intervention, there was about a 6-pound weight loss, a 4-millimeter reduction in systolic blood pressure, and a potential improvement in hemoglobin A1C in the group that got assigned to the active intervention. So basically good news, tested a theory. From my perspective, the question is, how much does that intervention effect reflect a novel theory, since many of the attributes of the intervention are actually what we do anyways in behavioral interventions. We try to encourage social support, engagement of family and friends. We even require, for some of our behavioral interventions, witness weights, which are all ways to try to get your family or get accountability into an intervention. So I think that they'll have to explain a little bit more about the intervention and address that issue. But it was encouraging, and I think the fact that they did this, it's a group from Harvard. They didn't go to their backyard in Boston. They went to, I think a dirt poor area where the median income is less than 20,000, and they did an intervention. So it's very admirable.
I thought the interesting part of that study was that the intervention is something that can be very applicable to a poor community. It doesn't require extra devices and extra tools and toys, etc. So
not a lot of professionals to carry it out.
Yeah,
right?
Yeah. So you can have that social intervention and have people that can do it easily and quickly if they're interested. So that made it very plausible.
Yeah. The potential scalability is quite appealing, and those are certainly communities that I think do need it. I mean, the prevalence of obesity in rural America, Appalachia in particular, is enormous.
Right.
And then the fourth trial was the trial of kind of teaching healthy habits to kids, essentially, for lack of a better word.
Yes.
And I'm always fascinated by this. And I guess one of the questions I have when I look at it is, one, will the knowledge that kids acquired at that age, will that be carried into an adulthood? And then do we have any evidence that there is that translation, and plus another translation is, do we have any data to suggest that any kind of markers of atherosclerosis are actually impacted by this?
Sure. Right. So I think, just to help the audience, this was originally a cluster randomized trial. It was done in Bogota, Colombia, and the active intervention group was actually it was done in schools, and so there was about 40 hours, I understand, per month of health education
and exercise
and a good part of it was with Sesame Street, and in the end those indices all improved after 1 year, and they felt compelled to then offer it to the control group, and then they presented a lot of data how knowledge, attitude, beliefs increased. I think the big issue from my perspective is that it's not waiting till adulthood. I think an intervention like that, the reminders and the issues and the presentation have to continue throughout, because we know, at least in adults, that you have to sustain an intervention, and the key issue is how do you do it in a very reasonable and expensive way, reach a lot of people. Those are some of the, and I think that they can't wait, because it's like preschool, but then you have elementary school, and then you have middle school, and then high school. It's going to, in my sense, there'd be a washout effect. So the problem, of course, is that there's a lot of migration. We might start off with, randomizing a classroom or something, but then the next wave is, well, how can you maintain that cluster? The cluster separates, and so it's going to be hard to study this.
So I agree that you're absolutely right. It does need to be maintained. I have a lot of research going on in physical activity, and we've learned from adults that many of them were very active in their youth, especially in high school and early college years, and then over time they just gave it up completely and other bad habits started to form. So I do agree with that. What I liked about the study was that they did start young, and they got these kids to change their attitudes, and a lot of what we do is based on attitude. So it may be that in some kids they may maintain those healthy behaviors, and even if they don't, the whole school will learn to be a little bit more healthy. So there may be some peer pressure to think about that, and they may be changes in the way the cafeteria serves food, or there may be changes in what's available in the vending machines because of implementation of this. Sure. People may just think healthier in general, and that's going to help kids at least as they're growing up.
Yeah, definitely, I agree with you.
It may not last.
And the other thing that they did actually is that they taught the healthy behaviors to the parents as well as the children. Right?
Sure, yeah. So there's a phenomena that it could bleed to the family.
Yeah, kind of reinforce itself, or the parents may reinforce it as the kids go through the stages of life. So, well, it was certainly an interesting session. I think, again, as we said in the beginning, truly aligned well with the AHA's mission. So, just the main hope is that many of these interventions, that the investigators who started them are actually going to continue to perfect them and turn it into something that hopefully will improve population health in the future.
I agree.
This is AHA Science News, Scientific Sessions 2013. Thank you for watching.